Hey guys.
Hey, Miss Huck.
Hi.
Am I doing my PowerPoint today, or is it next week? I guess I should look.
You do it today.
Oh,
I
great.
think I think it's just you and Nick that go today.
Oh, great. I mean, I'm done. I just haven't really looked at it in a while.
Well, you got a few minutes before here, so go ahead and start
That's what
looking at it. you know?
Are we going to do kind of what we did last week, like faster? Or are we going to keep it how it was, like the week before?
Since you guys are the only two going, then we have more time,
Okay, sounds
Hey,
good.
Nick, feel free to go first.
That's fine. I don't care.
Okay.
It's fine. It shouldn't don't feel like you have a bunch of pressure on you to, it's fine. You'll get points. You'll be good. Hey Jen.
Hi.
So we don't have like a ton of stuff to go through today, so um, we'll probably do those presentations first and get that done, and then we'll get into our PowerPoints a little bit. And then when we're done, maybe we'll do something else. I don't know. We'll see.
There's always interpretive dance.
You gonna do that for us, Brandon?
No, those days are over.
It's funny. Hey, does anyone have Brianna Toom in their clinical?
I do.
Did she drop?
I heard someone say she was talking about it, but I'm not sure.
Okay. I was just curious if anyone knew anything about that, because she hasn't said anything to me, and I thought, well, what the heck? Hey, Ebony.
Hello.
All right, so we got one more minute here. We're going to start out with our presentations first, so we'll get that going here in a minute. Let me make sure I have this so that you guys can share your screen. Looks like I do now. Hey, Maggie. All right. So it's 12:30, so we can go ahead and get started. So Nick, if you want to go first, you can go ahead and start sharing your screen, and we can go ahead and get started.
All right. Ready? Okay, so I did mine on Kaposi sarcoma. That's what the presentation's about. So what is Kaposi sarcoma? So it is a malignancy of the endothelial cells that causes purple or reddish lesions that line blood vessels. Generally it's caused by infection of the human herpes virus 8. I'll talk about the types in the next slide here, but there are some that aren't caused by that, and they don't know exactly why. It can spread to other parts of the body, which I'll explain here in a second as well. So here are the 4 types. You have classic KS, which is men of Italian or Eastern European or Jewish origin, which that's the one that's commonly seen. It's also seen in endemic. There's also an endemic one That's HRV positive, so these first two are the most common types. And then you have endemic, which is like an African origin, the eastern half of Africa near the equator, and idriogenic or organ transplant associated, which occurs during transplants, which really doesn't happen here. Obviously, this is more in other countries. So some risk factors, if you're immunocompromised, is generally the biggest risk factor, which is why the HIV AIDS is very common, because of you're just already immunocompromised with your CD4 levels low. As well as, and for some reason, older men of Jewish and Mediterranean descent, they don't know exactly why. It's probably something to do with the similar situation of living near Africa, near the equator. And then sexuality with multiple partners, homosexuality, bisexuality, unprotected sex fills in with the HIV stuff. So patho. So it's contacted via fecal oral route. So like this picture shows, so you get it, and what happens is the lesions develop through excessive proliferation of epithelial cells infected with the HHV8, and the white blood cells infiltrate these lesions, causing the inflammation, which causes the color change. And then new blood vessels are formed to try to help these cells like keep growing and keep creating more of the HHV8. And so they develop lesions on your skin, and then they call it like a tumor because it can travel through the bloodstream and go to different places. So that's why it can metastasize, but it's not necessarily a tumor. They say it's not really cancer, but it's filled in with cancer because of it being able to move to different places in the body and continuously grow.
Well, can it go to your organs?
Yeah, so I was going to go that. Yeah, it can go to your lungs. I have a picture in the next one. It goes, so like the common places, your skin, your oral cavity, and it can go to your lungs is common, and your spleen. There's not every organ, but any body tissue that has epithelial cells, it can technically go there and cause inflammation. So, which is why they consider it a cancer, but it's not like a cancer you can necessarily die from unless it blocks a vessel or in your lungs and airway or something like that. So yeah, the common places are your skin, your oral cavity, in the nose, eyes. I didn't show a picture, but there's actually some people that I've seen it on the eye, like on the actual eyeball, which is really weird. In your entire GI tract, they can be anywhere. Your lungs and your spleen are other common areas. So they're reddish purple in color. They can become darker blue, and if they're on your skin, they can actually develop like actual lesions and like open up. So I'll go through. I think one of mine is impaired skin integrity because there's a potential that you can actually have increased infection due to these. So how it's diagnosed, it's for what did I say there? I don't know. Physical exam of the lesions, a biopsy of those lesions to determine the HHV8, a chest exam to look in your lungs, a bronchoscopy to look inside your GI tract, your upper GI, and then you have your upper endoscopy and your colonoscopy to look throughout the rest of your GI. So treatment, generally, it's treated with the heart. It's just a common HIV AIDS treatment because it normally comes with HIV, because they use antiretrovirals and antivirals and protease inhibitors, which also affect this organism. But generally, they keep it throughout their whole life. Radiation therapy is also used, so they just try to radiate them. Chemotherapy, which is just kind of interesting because it's a lot of them are skin on the topical. They can actually inject the chemo directly into that cell, into that piece, and actually kill it from the inside, so it doesn't actually go out through your whole body, which is actually interesting. And then surgery, obviously, local incision. They can do an electrode dissection and curettage, which is basically so they remove the spot, the lesion, and then they take an electrical, looks like, I try to explain it. So they talk about it's like a spoon. So they remove it, and then they use like this electrode that's placed inside, and they electrocute the cells around it to then like cauterize them basically, so it can't go on to more farther. And then cryosurgery, they can freeze and destroy the abnormal tissue as well. So my first diagnosis was this impaired skin integrity related to disease process and evidenced by the lesions. So inspect and then monitor the site of the impairment at least once per day for color changes, redness, swelling, warmth, pain, and other signs of infection. Then educate on the skin and wound assessment and ways for monitor for signs, symptoms, infection, complications, and healing. Because early assessment and interventions can prevent serious problems from developing. My other one is to serve body image because it obviously discolors your skin, especially if it's on your face and things like that. So incorporate psychosocial questions related to body image as part of the nursing assessment. Then to identify the clients at risk for body image disturbance and use cognitive behavioral therapy to assist the client to express his emotions and feelings. And then I said risk for infection because this was kind of difficult because like there wasn't many problems you associate with it besides the physical ones. So I said risk for infection. So, assess the color, just like I was talking about, skin color, turgor accuracy, and then use sterile technique whenever you can. So my question, the first one is, how many types of KS are there? You show me the answer, or do you want someone to answer it?
I was hoping someone would answer it.
All right.
See if anyone was paying attention.
Was it like 4 or 6?
Yeah, there's
Six?
4.
4.
Yeah, there's 4.
Okay.
I'll go over them, but it's classic and HIV are the most, and then the epidemic are the most common, and there's endemic, and then there's the organ transplant one. What is the main sign of having Kaposi sarcoma?
Skin blotches, like
Yeah.
the brownish,
Yep.
nasty looking things.
Yep, the lesions. And then what are some ways it's treated?
Guys, he just talked about it.
Is it the, I don't know if I heard you correctly, the skin treatments or something because of the,
Yeah, so that's part of it. So you have heart therapy, which is like the most common, because it's most common people have it for like AIDS. It usually comes along with AIDS. So the heart therapy is very used often, but then also the chemotherapy of injecting the skin, the cryotherapy, surgical excision, and stuff like that. So yeah, radiation therapy, things like that. All right, that's my references.
All right, good job. So, did you know much about this before you did this?
I had heard about it and I knew it went along with HIV, but like I didn't know that it was considered a cancer. Really, I mean, like it makes sense. It's carcinoma, like it's considered a cancer, but it's not a cancer technically. So it's interesting. I thought that was interesting.
Yeah, I think it is kind of an interesting subject. Has any of you guys seen the movie Philadelphia with Tom Hanks? It's kind of an older movie.
Yeah, I saw it.
You saw it?
Yeah.
Anyone else
Yeah.
seen it?
I haven't.
come out.
If you,
It's old.
yeah, it's old, but
Yeah.
if you can, to me, it kind of brings home this point about Kaposi sarcoma because in the movie, Tom Hanks has HIV or AIDS, and he is a lawyer, and he's at this this office, and as he's getting worse with his sickness, he's starting to develop those lesions, right? And so he's trying to cover them up and stuff so people don't see them. And
Oh yeah, I remember.
and people
Yeah.
people start getting suspicious, and then he loses his job. So the whole point in that movie is this guy, he hires this guy as his lawyer, and they're trying to fight for his right to get his job back. He shouldn't have to not have his job because he has HIV. But
Right.
see, when they did this movie, this was back when people were still really scared about HIV and AIDS. And,
Mhm.
In the movie, they even show people like afraid to touch him or be anywhere close to him because of that. So it's kind of neat. If you guys ever get a chance to see any of it, they actually have this really dramatic part in the movie where he's on the stand and his lawyer says, "Hey, do you have any of those lesions right now? Can you show us what they look like?"
Mhm.
And he opens up his shirt and shows you.
Yeah. That
So
came
it's-
out like in the early 90s, I believe.
Yeah.
Yeah. It was a really good movie too.
Yeah, and they make him look so sick in it. Oh my
It does. It
Yeah.
does look horrible.
Yeah.
Yeah.
So it's pretty cool. So if you get a chance, go look that up because then you will never forget that, All right, Brandon, you ready?
Sure. All right, let me share my screen. Did that work?
Yep.
Hey, sweet. Let me move this thing here and that, and okay. So my topic was TB and how it's related with HIV together. And I actually had a DVD about tuberculosis, and it was called The Silent Killers, and I really liked that
Oh.
title, so I shamelessly stole it. So what is TB? It's the world's biggest infectious killer. It is treatable, curable, and preventable, but it's caused by a bacteria called Mycobacterium tuberculosis, and it is spread in the air. It usually just affects the lungs, but believe it or not, it can attack other parts of the body, such as your kidneys, spine, or brain, and it can cause death if it's not treated. So it spreads in the air from person to person. It can be inactive or active. And when it's inactive, it's called latent TB. So that's how you can still test positive on like a tuberculosis test, even though you're not actively contagious, and you can still work in healthcare and things like that. So what else was I going to say? It weakens the immune system. And we'll get into that later on how it's related to HIV. But people who have both HIV and TB should be treated for both diseases. However, when you start treatment and what medicines to take depends on their individual circumstances. So some of the common symptoms of TB would be persistent cough that may have blood or sputum, chest pain, fatigue, loss of appetite, weight loss, fever, and night sweats. And then how do you treat tuberculosis? Tuberculosis medicines are used to prevent the latent TB from advancing to where it's active. It depends on whether you have latent or the actual disease. People with both HIV and TB, they are treated for both. As I said earlier, talk to your healthcare about treatment that works for you. And then HIV. HIV stands for human immunodeficiency virus, which is a virus that causes HIV infection. So when someone says they have HIV, it can refer to the virus or their infection. And AIDS stands for acquired immunodeficiency syndrome, and that's the most advanced stage. And remember this, guys, HIV attacks and destroys the infection-fighting CD4 cells of the immune system. And that makes it difficult for the body to fight off other infections. So without treatment, HIV can gradually destroy the immune system, which then advances to AIDS. So what is the connection between HIV and TB? So tuberculosis is an opportunistic infection, which means it'll be more severe with those who have weakened immune systems. And we just discussed that HIV actively weakens your immune system. So if you have HIV and latent tuberculosis, the latent tuberculosis will most likely advance to the deadly form of tuberculosis. And that in turn can cause the HIV to worsen. So it's like a really bad cycle of just not fun. So you would be treated with anti-retroviral therapy, which protects the immune system and prevents HIV infection from advancing to AIDS. And that will in turn help keep latent TB from advancing. So I thought this was interesting. As many as 14 million people in the United States have been exposed to tuberculosis, but our immune systems keep us from getting sick. So only 10% of those who come in contact with it do develop the disease. However, as we said earlier, when someone has HIV, that weakens their immune system. So once the bacteria causes TB to enter the body, usually through the lungs, the bacteria are able to multiply, invade, and cause full-blown tuberculosis. So should people with HIV get tested for tuberculosis? Yes, all people with HIV should get tested, preferably at the time of HIV diagnosis. If the test shows that they do have latent TB, additional testing is needed. TB is contracted by breathing air that contains an infected person's droplets, so like coughing, sneezing, and just talking in general. TB is not connected to sexual activity or drug use, which is how IV is transmitted. And HIV can be contracted regardless of your TB status. So latent TB and HIV. Someone with latent or inactive TB can go years without experiencing any symptoms. But once you get HIV, as we said earlier, your latent TB can likely spread. So it's definitely not good to have HIV or TB, really. Latent tuberculosis is safely walled off in a small area of the lungs in most people with healthy immune systems, but it can still be passed from others. And tuberculosis, as we said, they play off each other's weaknesses. HIV weakens the immune system and makes it more vulnerable, encouraging TB to develop, and tuberculosis takes advantage of the body's low defenses, move in, infect, and spread. So the combination of illnesses creates the perfect scenario. And when someone's infected by an HIV-infected person who has active tuberculosis, is considered to have AIDS. So it kind of butchered how the screen looks, so it's kind of hard to see, but my nursing diagnoses, I put impaired social interaction related to inertia, as evidenced by feelings of seclusion, avoids contact with others, and lacks eye contact. So someone who has these diseases, they're going to be socially isolated because, you know, as Ms. Silk said earlier, no one's going to want to spend time with them. They're going to keep to themselves. So I put as an intervention, provide activities that require minimal concentration, such as drawing, playing simple board games, things like that, just to kind of take their mind off of their problems. Another diagnosis is fluid volume deficit related to active fluid loss, as evidenced by excessive vomiting, because obviously when you have tuberculosis and HIV, you're going to be vomiting quite a bit. So if they can tolerate oral fluids, give what fluids you can, provide fresh waters, things like that. And then risk for depression related to loneliness, as evidenced by suicidal behavior. A lot of people who have these diagnoses do sadly commit suicide, or they consider it. So you always want to have them on suicide precautions, especially if they're showing signs of depression. And then the 3 questions. Tuberculosis can attack other parts of the body other than the lungs. True or false?
True.
True.
It was true. And what cells of the immune system does the HIV attack and destroy? Do you guys remember?
CD4.
It is CD4. Good job. And then, so this is kind of summarizes the whole PowerPoint. Basically speaking, how does having HIV and AIDS make one more at risk for active tuberculosis?
Compromised already.
Yep, and those are the answers. HIV weakens the immune system. So, and then my references, and that's it.
Hey, nice job. So I know you might have thought that was weird that I gave you that topic, but I figured, you know, we talked about TB early on in the term, and I figured it's always good to have a refresher on that stuff. And plus, it kind of does, you know, come full circle, because when we talk about HIV next week, you know, it's all right there.
No,
So-
I enjoyed researching it, honestly. It was a little simple. Like I had trouble finding enough information,
No, you did fine with it.
but I enjoyed researching it, honestly.
Okay, good. All right, and then the stuff that we'll do next week for the rest of you guys who have to present, that's all kind of review type stuff as well. So it's more like respiratory everything. And that's okay, even though we're not talking about that right now, because you need to refresh yourself on that for the final. So that's kind of why I did that. All right, does anyone have any questions for Brandon? Okay. All right, nice job, you guys. Thank you.
Thank
If you guys didn't turn them in on Canvas, make sure you do that real quick, so I have that to grade. All right, so we are going to talk about hypertension and vascular stuff today. So I'm going to start with the hypertension. So let me see if I can pull this up. Okay, so with this hypertension PowerPoint, a lot of this is stuff you should already know. So, you know, hopefully a lot of it will just be review for you. The beginning part of this just talks about the mechanics of blood flow, because when we talk about your blood pressure, it does kind of affect your blood flow. You know, what is happening with how blood is flowing through your body. So when we talk about blood flow, it's affected by a few different things. So the diameter of the vessel, so how big the vessel is for it to get through, the length of the vessel, the pressure at either end of the vessel, and how thick the blood is as it's trying to get through. And then the fifth thing is contractility of the heart and arterial blood vessels. All right, and then this is talking about what are some things that affect blood flow in our vascular system. So we have some ways to like detect if there's an issue, you know, in our body. So our body does this all the time with all of these different things. Like when we talk about some of the other, you know, different disorders that we talk about, we say that the body will recognize that there's a problem and it will kick in and do something. So same thing here. So we have this auto-regulation that happens. So even though our blood pressure can kind of be up and down and not necessarily 120/80 all of the time, our blood flow still stays the same. So it still gets through, no issues. Our body also has the ability to formulate collateral circulation, which I don't know if you guys have heard a whole lot about that before, but you know, at times you'll see, maybe you'll have a patient that had a heart attack or something, and you'll talk to them a little bit and they'll be like, oh yeah, my physician told me that when they went in to do my bypass, they saw that I had developed some collateral circulation. So sometimes our body will do that. It'll sense that you aren't getting enough blood flow to an area, so it'll start forming, you know, new pathway to get around that blockage. So you'll see that in certain areas, like in the heart, and sometimes even in your extremities, like in, you know, when we talk about this vascular stuff. All right, so we have nervous system control of our blood pressure. So the first part of this is the parasympathetic nervous system. So it regulates our heart rate through the vagus nerve. And we also have what we call baroreceptors that are located in the aortic arch and the carotid sinuses that are sensitive to pressure changes in the vessel walls. So like for instance, if we have a lot of pressure, you know, as we're trying to get this blood through a vessel, if we have increased pressure, typically that means that the vessel is tight, that we can't get blood through it very well. So that's what's causing the increased pressure. So these receptors would detect that. So they would kick in and, you know, do something about it. So this says an increase in pressure causes stimulation of the vagus nerve, which in turn will decrease the heart rate. So that will kind of help with your pressure. All right, so there's some different things that affect blood flow with the sympathetic nervous system. So with the sympathetic nervous system, it talks about how our arterioles will dilate or constrict to maintain this peripheral resistance and tone. The peripheral resistance is, for example, like your vessel will dilate if it sees that you're having a really hard time getting blood flow through that vessel. So it'll open up some more. So that's going to decrease your blood pressure. And then if it senses increased resistance, you know, it'll be the opposite the other way. So it'll constrict and increase resistance if you have, you know, like a really low blood pressure, and it'll increase your blood pressure. All right, so things that we have in our blood also affect blood pressure regulation. So things like angiotensin and vasopressin, they're vasoconstrictors. Also histamine is a vasodilator. And epinephrine and norepinephrine act as vasoconstrictors. So those are all things that we already have in our blood to kind of help with some of these issues. So in your notes, I would like you to write a couple things down. So there's really 3 factors that are responsible for creating blood pressure. So we've got cardiac output, peripheral resistance, and blood volume. So what is cardiac output? Cardiac output is the volume of blood that is pumped per minute by the heart and it's determined by heart rate and stroke volume. So if you have an increased cardiac output, then you will have an increased blood pressure. If you have a decreased cardiac output, you will have a decreased blood pressure. All right, let me tell you what stroke volume is. So stroke volume is the amount of blood pumped by a ventricle in one contraction. Try not to talk so fast in case you're writing. So again, we said cardiac output is determined by heart rate and stroke volume. So again, your stroke volume is just that amount of blood pumped by a ventricle in one contraction. All right, the second thing, peripheral resistance. When we talk about that, remember I was talking about your vessels and how if blood is having a hard time getting through, it means your vessel is kind of smaller or constricted some. So believe it or not, our vessels are surrounded by smooth muscles in the arterioles, and they will constrict and cause the inside diameter to become smaller and increase resistance and increase blood pressure. So the opposite happens if they relax. So obviously, if it gets bigger, you're going to get decreased blood pressure from that. So that's kind of what's going on with peripheral resistance. And then with blood volume. So your blood volume affects your blood pressure. So for instance, if you say you work in the ER and someone comes in and they have a huge amount of blood loss. So if you lose a lot of blood, your blood pressure is going to go down. So typically, what we do to kind of fix that is give them blood. They lost a ton of blood, so you're going to give them blood to replace what they lost. And then just a couple other things, when you're talking about blood volume. So if someone is just, I don't know, they don't have enough fluid volume like outside their cells, sometimes we'll give IV fluids or colloids, right? So that will help fix that, and it'll increase your blood pressure. So when you guys work as a nurse on the floor, or at a facility, wherever you work at, if you call and you say, hey, my patient has a really low blood pressure right now, what would you like me to do? 9 times out of 10, the physician or resident will give you an order to give fluids, like a bolus of fluids. All right, what do diuretics do to your blood pressure?
I assume it'd lower it, right?
Yes. So always remember that. So when you're giving someone a diuretic, you should always check their blood pressure. Because why would you still give it if they are, having an issue with their blood pressure, right? So you always need to know that beforehand before you give their diuretic. All right, and then just some basic definitions here. So your systolic pressure, that top number, represents the ejection of blood from the heart, determined primarily by the amount of blood ejected. The bottom number, the diastolic pressure, is going to represent the pressure remaining in the arteries at the end of systole. It depends on the ability of the arteries to stretch and handle the flow of blood. And then pulse pressure. This is the difference between the systolic and diastolic pressures. So sometimes when you talk about certain disorders, they'll talk about how you have a narrowing pulse pressure. That's what they're talking about. They're talking about your systolic and diastolic are getting closer together. That usually is a problem. And then when they say mean arterial pressure, the MAP, which I'm sure you've seen that on a Dynamap before, this is the average pressure within the arterial system at that time. All right, so again, just to kind of recap some of the things that influence our blood pressure. So our autonomic nervous system influences our blood pressure. We also have renal influences. So the renin-angiotensin system affects your blood pressure. The hypothalamus is stimulated to secrete vasopressin when the blood pressure falls below normal. This increases conservation of water, and then it's going to increase your blood pressure. So you remember talking about vasopressin when we talked about antidiuretic hormone, you guys? So it actually will affect your blood pressure as well. Okay, so I do want to mention atherosclerosis, which I can't say it very good. Atherosclerosis. All right, so what this is, it's a gradual thickening and narrowing of your arterial lumen. So sometimes you'll hear it called hardening of the arteries. So this happens over time. It doesn't happen like overnight or something. It happens over a period of time. So it's a slow process, and it can cause a number of problems. So you can get an MI if you have this. You can have a stroke. You can get an aneurysm. You can have peripheral vascular disease, hypertension, of course, and also renal failure. All of these things can happen just because you have atherosclerosis. So here's some risk factors for developing this. So there's modifiable and non-modifiable factors. So modifiable means it's things you can fix. So elevated cholesterol and triglycerides. So sometimes when you get labs back, like if it's on you especially, you're like, geez, what can I do to fix that? Well, there are things you could do. You know, if you exercise more and you eat differently, that will affect this. So those things, you know, that's something that's modifiable. The sedentary lifestyle, we talk about that all the time. If you just sit around all day in your house and you do nothing, you don't move around, you don't take a walk, you don't do any type of exercise, it's bad for you. It causes a ton of problems. So that's something you could fix. Obesity, which a ton of people have a hard time with this, that we have pretty much a huge majority of our society is obese. And it's a big problem. And part of it, I think, is because, like I was just talking about this in my one class today, my class. I was saying that prevention is such a big problem in the United States that I feel like physicians don't sit there and really talk to you about things that you should be trying to fix. What do you guys think? When you go to your doctor, does your doctor sit there with you and talk about things you could do to prevent problems?
I mean, not really, not that I can think of.
No.
Yeah, so like I was saying, so I had to do a discussion post about this today. I was just talking about this. So I was saying that when I go to my doctor's pretty good, but she doesn't really spend a ton of time talking about anything prevention, you know? Like if she noticed that I had an increase in my weight from last time she saw me, she might mention it, but then she kind of leaves it there. She doesn't tell me, oh, what can you do to fix that? Or, hey, maybe have you ever tried to do this? You know, I was saying in my post, I said I would respect her so much more if she would spend time and do that. Because prevention, if you really think about it, if we spent more time trying to prevent problems from happening, then we wouldn't have so many of these chronic illnesses. You know, if you really focused a ton on prevention, we wouldn't have such a huge problem with all of these other things. So anyway, obesity, that's a big issue. Stress is also something that you can hopefully do something about. Sometimes it's hard, but there are things that can help you decrease your stress. And then smoking, you know, so all of these are modifiable. Non-modifiable would be things that you can't really change. So if you just have it that runs in your family, unfortunately, you can't do anything about that. You can be like the fittest person on earth. You can have like hardly any body fat, and you could still end up having an MI. So it's just because it's in your history, and you can't do anything about that. Age, you can't change your age or your race. Gender, sure, we can have a sex change or whatever, but really it doesn't change what you were born as, you know? So gender is another thing here. So it says men are at greater risk for atherosclerosis than women, but then after age 60, that changes. Women start to have an increase in it. Okay, I also put on here a little bit about cholesterol because when we're talking about all of this, this is a big part of it. So when you get atherosclerosis, this just means you get all of this buildup of junk in your arteries, and it's usually, you know, cholesterol that's built up in there because you're eating wrong, you're not exercising and doing all these bad things. So cholesterol is huge here. So a normal cholesterol would be less than 200. So we hopefully all know that. But the other values maybe you're not that familiar with, so I put them here. So hopefully, you know, you need to be looking at these and really try and memorize these. So low density lipoproteins, is that a good or a bad cholesterol?
Isn't that the, would you say the high or the low?
The low. Is that good or bad?
Bad.
Bad, right? And then the high density is good. So you would rather have more high density lipoproteins than low density, right? So there's the levels right there. And then triglycerides is another portion of your cholesterol that you should be keeping an eye on. So if your triglycerides are greater than 150, that's a huge problem. So those are some things that you need to kind of keep an eye on, especially all of us when we go to the doctor and we get our blood work and stuff. If you start to see some of that creep up, you need to start doing something about it. All right, I know this seems stupid, but I put some of these steps to taking a blood pressure here. And I know it seems very basic, and you guys are all like, I've done a blood pressure 3 million times, but we are all so used to doing it with a Dynamap or whatever that we don't always remember the actual, hey, this is what I would do next if I did a manual. So I put it here just to remind you. So make sure you look through that. It's important to know. You always need to know how to do a manual because, you know, you can't really rely on those blood pressure cuffs at the hospital and stuff because a lot of times they'll malfunction. I know when I used to take people's blood pressure that had AFib, anyone that had an irregular heart rate, it would totally screw up the blood pressure. It would, you know, it would read totally wrong. So you would have to do a manual then. Okay, the next thing here. On this slide, it's talking about, hey, what are some things that can affect my blood pressure? So just so you know, like if you go in to take someone's blood pressure and they just came inside from smoking, like you know how you'll see people all the time, patients who sneak out to go smoke when they're not supposed to. So if they just came in from smoking, what's that going to do to their blood pressure?
I mean, it'll be higher, yeah.
Yeah. So some of the, I'm just trying to say here, sometimes certain things are going to affect your blood pressure. So if that's the case, maybe you should come back in like 10, 15 minutes until it, you know, normalizes, right? So other things I have listed here, you know, ethnicity, gender, position changes, exercise. Like if you were just walking in the hall and came back, maybe your heart rate's up because you were just walking in the hall, you know? Your weight can affect your blood pressure. Anxiety can. So I'm sure we all know all about white coat syndrome, right? So you go to the doctor and they sit there and they take your blood pressure and you get nervous. So sometimes everything goes up. So that's another thing that you need to think about. And then even medications and time of day. Sometimes certain times of day, your pressure is going to be a little different. So those are some things just to keep in mind about. Also, we also want to make sure we always have the right size cuff because if we put on the wrong size, it's going to affect the blood pressure. So if we put on a cuff that's too small for someone, it's going to make their pressure be higher. than it really is. If we put on one that's too big, it might be lower than it really is. So you need to have the right size. Okay, so this is one of the most important slides in this whole presentation. So there were different classifications put out for blood pressure in 2017. It was right at the end of the year. So even our book is not current in this. So if you should have a question that has to do with this on your test, just know that I have changed it so it reflects these new classifications. So with blood pressure, a normal blood pressure is going to be less than 120/80. And then what's different in these classifications is this. There is now a category called elevated. Before, if you looked at the older classifications, they had something called pre-hypertension. So now they've done away with that and they've added this elevated category. So elevated just means that you're a little bit higher than 120. So like maybe you're 124, which isn't bad, but it's elevated, right? And the bottom number is going to be less than, or wait a minute, the bottom number is less than 80, it says. So like you might just be just a teeny bit off with your blood pressure, and they're going to just consider that elevated. They're not going to consider you as having a normal blood pressure. Then stage 1 means that your top number is going to be anywhere from 130 to 139 for that top number, and then the bottom number would be anywhere from 80 to 89. So either one of those numbers could be up a little bit. Stage 2 means that the systolic is at least 140, or it could be higher, and the diastolic is at least 90 or higher. So when you look at the old classifications, listen to this. So the old classification for stage 1 used to say 140 over 140 to 159 for that top number. And the bottom number used to be 90 to 99. So look at the difference here on this slide. Why do you think they changed it to make everything lower? What do you think was the purpose of that?
Is it like easier to treat when it's lower and they don't want it to get like super high too late?
Kind of. So you know how, like when we talked about blood sugar, how we said we want to always have real tight control of our blood sugar, right? Because if you get it out of control, it's really difficult to manage then, and then you're at risk for a bunch of other things if your blood pressure's out of control, or your blood sugar. So same thing here. If we have really tight control of our blood pressure, we're not going to end up, getting all of these other problems like, heart attacks and strokes and all of these things. So before, when all of these levels were a lot higher, we were letting people go forever before we would put them on, medication and stuff. Now we're treating them sooner by doing this. And if you treat them sooner, then it's more of a prevention type of thing. So we don't, get all of these bad issues from our blood pressure. Does that make sense? Yes? No?
Yeah, it makes sense to me.
Okay. So I know a lot of people think, wow, what the heck? These are pretty low. But it really does make sense when you think about it, because if you're preventing something from happening by doing this, it's worth it, All right, so look down below. There's something called hypertensive crisis. So this is kind of important for you guys to know as well. So hypertensive crisis means that your top number of your blood pressure is over 180 and the bottom number is over 120. And it says with patients needing prompt changes in medication, if there's no other indicators of problems or immediate hospitalization, and there's no signs of organ damage. So your pressure's pretty high at that point. So that's considered hypertensive crisis. And we'll talk about that on another slide here in a second. Okay, so this is another thing that I need you to get down and understand. So there's a difference between what we call primary hypertension and secondary hypertension. So primary hypertension, this is pretty much what most people out there have. So about 90 to 95% of all cases are considered primary. So the cause is unknown, but you have contributing factors present. So like you can't just go and say, oh, this person has high blood pressure because they have high cholesterol. You can't say that. It's not like the actual, there's no like definitive thing to say, yes, this is what's causing it. So yes, we know that like if you have a high body weight and you smoke and you have a lot of stress, all of that contributes, yes, but it's not necessarily the actual cause of what caused this. Okay, so that's primary. Secondary is different. Secondary is when you have high blood pressure as a result of something else that you have going on. So like, you know, in our last group of stuff that we just talked about with endocrine, we talked about pheochromocytomas. So if someone had that, they would have secondary hypertension because the only reason they have it is because they have that tumor. That tumor is the one, what is causing it. Or maybe I'm pregnant and I have preeclampsia. You know, if you are pregnant and you have that, that is your cause of your hypertension. It's not that you had it before, it's that. So again, secondary, it's not like the majority of cases. It's, you know, a smaller group of people, but they have something else that's causing their hypertension. Okay, so this is something I want you guys to understand about. So a couple slides ago, we just talked about hypertensive crisis. So when I say hypertensive crisis, malignant hypertension, those are kind of the same things, okay? So malignant, oh, I put hyperthermia on here. Geez, I just noticed that. It should say hypertension. So anyway, so malignant hypertension is a sustained increase in diastolic pressure that's unresponsive to treatment. So that bottom number is high continually no matter what you're doing. Okay, when I'm talking hypertensive crisis, remember we said that meant that you had a, you know, top number over 180, bottom number over 120. So if you're at that point, that's a problem. You are concerned about this person because their pressure is so high. So this might be someone that you would actually admit to the hospital. Now, this is what makes it different from hypertensive emergency. So there's a difference between hypertensive crisis and hypertensive emergency. So what makes it an emergency would be if I had those things happening with my blood pressure, but now I also have end organ damage. So now that my pressure has been up for so long, now I actually have problems with my kidneys or my heart or something else because my pressure's been up for so long. So either one of these two types of patients, whether it's hypertensive crisis or emergency, they should be admitted to the hospital. Now, typically someone with hypertensive crisis, they just have the high blood pressure. They don't have any signs of organ damage yet. So pretty much what you do for them is you just treat them with different, you know, blood pressure medications to get them down to where you want them to be. So sometimes they'll treat them with oral drugs. Sometimes things like labetalol, clonidine, or captopril. But then hypertensive emergency is a little bit different because we're already seeing damage to our organs. We can't wait on something oral to fix this. We need to fix something quick. So what we're going to do is we're going to give a medication called nitroprusside. Now, this is not the same thing as nitro. This is different. Nitroprusside, if you give it, it has the ability to decrease your blood pressure instantaneously. And you give it in the IV. It's always given IV. So it has a half-life of 2 minutes. So if someone is on this, they cannot be on a regular unit. They have to be in the ICU when you're giving this. Now, this medication is no joke. Because it works so quick, you have to constantly monitor them really closely, and you don't want to leave them on this drug for a long period of time. So as the drug stays in your system, it metabolizes down to the equivalent of cyanide. And what is cyanide? Cyanide's a poison, right? So it can be really toxic to your body. So you don't want to have them on this for very long. You're just trying to get their blood pressure down quick, and then once it's down to where you want it, you're going to put them on something else that's a little safer. All right, when we talk about end organ damage, the organs we're talking about are going to be your heart, your kidneys, your brain, or even your lungs. So how would you know if you had heart damage?
You'd see it on their heart monitor?
Possibly. You might see it on an EKG, but what else would tell you if you had heart damage?
They'd be in pain.
Anyone could have chest pain. That doesn't mean you have heart damage. What's more definitive? What's going to tell me?
They turn cyanotic, maybe?
Well, they've had an MI. If they have an MI, they have heart damage, right?
Okay.
So when we have a myocardial infarction, that means that that part of our heart dies, right? So there's actual damage there. We don't have oxygen to that area. So at this point, if this person's pressure is high like that, they're going to have an MI associated with this. So you're going to know they have heart damage, okay? How about the kidneys? How would you know if someone had kidney damage?
Your labs and your symptoms.
Yeah. So just think of the stuff we just talked about. So what labs would we be looking at?
BUN and creatinine.
Yeah. And then probably their urine output would be different, right? It might be lower. All of those things that we talked about with like acute kidney injury and chronic kidney disease, those are the things we'd be looking at. And so if they had this stuff, we would know they definitely have a kidney issue. How about the brain? How would you know if they had a brain injury?
Signs and symptoms.
Yeah, but a little bit more than that.
A testing.
So think of what I said about the heart. How do you know if you have injury to the brain?
You do neural assessment?
Yeah, but that's not what I'm getting at. So remember we said MI for the heart, so stroke. Okay, so if someone has a stroke, that is injury to the brain, right? Do you understand what I'm saying? So if you have a stroke, it just means that you have a clot that broke off and lodged in your brain, and it caused that area to die off, just like it would in your heart. Like when we were talking about with the heart, you would have that area die off because it doesn't have enough oxygenation to it, right? And that's why they're having all their weird symptoms of their stroke. Does that make sense?
Yeah.
Yeah.
All right, and then the lungs would be another one. So the lungs you would just kind of see with symptoms that they're having. If they have an issue with their lungs, they're going to probably go into respiratory failure and stuff because they can't breathe. So that's kind of what we're looking at with that. Okay, this is another term that I just want you to know, essential hypertension. So a couple slides ago, I had the slide that talked about primary and secondary hypertension. Essential hypertension is primary hypertension. So same thing, okay? All right, so there are non-modifiable and modifiable risk factors to help with your blood pressure. So again, things we can't change. We can't change our age or gender or ethnic group or our family history. But things we can change would be, you know, obesity, stress, substance abuse, those types of things. When we diagnose someone as being or having high blood pressure, we don't just diagnose it from one reading, right? Because, excuse me, because if we did that, that would just be crazy. So one high reading is not going to diagnose you. So what they do is typically if they're concerned that you're having an issue, they will have you come in and check your blood pressure probably 2 or 3 different times. So they may have you come in one time in the morning and they'll check it. They may have you come in one time during the afternoon and check it. They're going to do different times of day just to see what you're like, because your pressure is different on those different times of day and they want to see if it's really an issue. So the other thing, they're also going to do a really good physical assessment with you. They're going to check to see if you have murmurs, if your pulses are messed up. They're going to check for blocked arteries, that type of thing. Probably do an EKG, maybe even an echocardiogram along with this. All right, so when we talk about treatment, so we're not going to treat someone if they're just in that elevated stage. If they're in that elevated stage, we are going to just try to tell them things that they can do to like modify some of their risk factors. So, hey, if you have high blood pressure, I want you to try and really start watching how much salt you take in. So have a decreased salt intake. You know, like really watch that and teach them about how to read food labels and stuff like that. You're going to talk about exercise and how exercise can help with your blood pressure. You're going to talk about losing weight and keeping track of their weight, and maybe they have these different apps out there now that you can get on your phone that like you can scan different things that you eat and it'll keep track of the calories that you take in every day and stuff. So there's all these things like that that you could do that would help modify some of those things. So if you're at the elevated stage, that's the kind of stuff they're going to do with you for treatment at first. Once you get past that, now you're in stage 1 hypertension. So stage 1 means that we're going to actually treat you with medication now. So usually it's just oral pills and it's going to be diuretics. That's one of our first things that we're going to start with. And usually it's going to be a thiazide diuretic. So like my husband has high blood pressure and everyone in his family has it. His grandfather, his dad, he had it at the same age, like all of them. And he has a bunch of brothers and some of them have it too. So it's crazy. It runs in his family. Plus there's other things that, you know, he could do better, that he would be better with. But when he first got diagnosed, he got put on hydrochlorothiazide. So that's kind of a typical first-line drug for hypertension. So hydrochlorothiazide is a thiazide diuretic. And the thing about that is it has a little bit of that water pill in it, like you know, because we know it's a diuretic, so it's going to make you pee. But it also can affect your potassium level. So any diuretics can do that. So as you're getting rid of fluid, you're also getting rid of some of your potassium with that. So sometimes people will end up having to go on potassium along with it. So again, stage 1, treat it with a diuretic, whether it's thiazide loop or potassium sparing, okay? Stage 2, if you get to that point, they've already tried the diuretics with you and maybe that's not good enough now. So now you're stage 2 hypertension. So we're gonna treat it with a combination of things. So now we're going with a diuretic and a second medication. So it's either going to be a beta adrenergic blocker, an ACE inhibitor, or a calcium channel blocker. So when we talk about these different groups of drugs, I know you guys all have a hard time with PHARM. But you need to start getting familiar with certain little things about these drugs to make you remember. Do you guys remember anything specific about ACE inhibitors? Like when you see the word ACE inhibitor, what kinds of things do you think of?
Doesn't it have a dry cough?
Yes, you can have that associated with it.
They treat high blood pressure. I remember that.
Okay. What else? What kind of ending does it have that goes along with that drug?
Pril.
Pril, right? So Pril. So that's definitely something to remember. So every time you see that, you'll be like, oh, that's an ACE inhibitor. All right, so we know that it's given for blood pressure, so we know that it's supposed to take your blood pressure down. So what other kinds of side effects might you see with that?
The orthostatic hypotension thing.
Yes. So what do you know about orthostatic hypotension? What do we tell people, if that's
So
a possibility?
rise, when you're getting them off the bed, have them sit and dangle their feet for a minute or two before they get up.
Okay. So these guys are going to be more at risk for falls too, especially if it's an older adult, right? What else might you have a hard time with an ACE inhibitor? What would be another side effect that we need to keep in mind?
Do ACE inhibitors, is that affecting the potassium or your heart, or am I mixing it up with?
It can affect your potassium. Thank you
Okay.
for saying that. I'm glad someone said it. Okay, so with this, believe it or not, with ACE inhibitors, you can actually have a high potassium with this. So that's something that you need to keep in mind. So anytime you have a patient on that, you need to check their potassium in their labs to make sure that it's doing okay, because that could actually be a side effect. All right, good job. All right, we'll talk about some of these here in a second, but let me keep going here. And then when we have, obviously, we talked about what you would do for elevated, stage 1, stage 2, and then if it's past stage 2, if you're to the point where you're super high, you have to come to the hospital, that hypertensive urgency or emergency, you're going to use more significant medications at that point. So labetalol, nitroprusside if it's hypertensive emergency, and then other things like nicardipine. So those would be a couple examples of things they would use. All right, this is just first line treatment for hypertension. We already talked about this. Hydrochlorothiazide is typically the one they first use. And then look at this. It's effective in producing a 10 to 20 millimeter of mercury drop in your blood pressure. So it actually works really well. So we always want to monitor electrolyte levels. But look at this. Also monitor uric acid levels. So remember with our kidney stuff, we talked about kidney stones. So someone that's on this could be at risk for that. They could be at risk for uric acid kidney stones. So that would be something to watch for. And then ACE inhibitors, our big one to remember is lisinopril. That's typically the one we see the most. So again, that dry cough can be something, and actually, talking about my husband again. So my husband recently had to go on lisinopril, and he had this dry cough, and it was horrible. So recently she switched him to something else. So now hopefully we don't hear that cough anymore. And again, here's the thing about the high potassium that you could see. And then angioedema is a possibility with this drug, but it's not really common. So like if you look this up in a drug book, sometimes it'll give you percentages of side effects that you would see. The percentage would be super low for angioedema, but it is a possibility. So when I say angioedema, what does that mean?
Edema. It's edema around the heart, right?
No.
No.
It's like an allergic swelling, right?
Okay, so what do you look like when you have angioedema?
Like you're having an allergic reaction. You're all puffy, isn't it?
Yeah, let me see if I can find a good picture to show you.
Oh, look at that. Ew.
Okay, so you're worried about their airway. So when we say angioedema, it's like sometimes you'll see it like with their eyes and stuff and their lips, but you're worried about their airway, that their airway's going to cut off. So I've had people who have been admitted for angioedema, and they're admitted because you're worried that they're going to lose their airway. Look at this poor guy's lips here. Oh my gosh. So it can be horrible. And look at this guy here with his tongue. His tongue is huge. So like that airway would be so small, you'd be super worried that he's not going to be able to breathe anymore, right? So that's what we're talking about with angioedema. So like sometimes you could see the lips be really big, the tongue, you just all that swelling in that airway is our main concern. Okay, here we go. All right, and then the next one is talking about beta blockers. And most of us kind of are familiar with beta blockers. We know that the LOL, the metoprolol is our big one that we always look at, right? So with beta blockers, some of the big things you got to remember, you'll have hold rates for those. So if your heart rate is less than 60, you're typically going to hold this and not give it. Sometimes you'll have a hold rate for their blood pressure as well. So I have seen some physicians write if their systolic is less than 100, you could hold it. But typically when you give a beta blocker, it affects the heart rate more than the blood pressure. It affects both, but more so the heart rate. So some big things to remember with beta blockers. So they can mask signs of hypoglycemia. So if you have someone who's on this and they're diabetic, usually they wouldn't be able to tell you, like you would be able to see some things with them to show you that, hey, their blood sugar's going down, but this can actually mask that. So instead of them being able to tell you, oh, I feel jittery or I feel like, my blood sugar's going down, they won't know. So you have to really keep a close eye on people like that. Other things, these beta blockers can cause bronchospasms. So bronchospasms are a big deal, especially if someone already has a lung issue going on. So if they have asthma or COPD or something and they're on a beta blocker, if they start having a bronchospasm, that's going to be a huge deal. So it doesn't mean that someone like that can't be on a beta blocker, because you'll see all kinds of people with asthma on them, but you have to just be careful. You have to be aware that that could be something that could happen. So other things you'd be worried about here, obviously we're giving this to help bring their blood pressure down. So other things to watch for would be a low heart rate, like we said, maybe depression, bradycardia, that kind of thing. All right, and then calcium channel blockers. These are kind of harder to remember for me. I don't know about you guys, because some of the other ones have that ending and it's like, oh yes, I know what that is. But for calcium channel blockers, there are so many different types of them with different endings. It's hard to distinguish one from another. So I don't know if you could see these real well, but like verapamil, diltiazem, nifedipine, all of those are calcium channel blockers, but see, they all have different endings. So it's hard to remember those just because of that. But to me, with beta blockers and calcium channel blockers, they're really similar to me. So you still have hold rates that you have to worry about. So that heart rate less than 60, that would be something you would do here as well. You still can have low blood pressure, low heart rate from this one. But one thing I want you to pay attention to on this, like with calcium channel blockers, peripheral edema is something that you need to watch for. Peripheral edema. So a lot of people forget that. Okay, so modifiable changes with our blood pressure. So again, we can mess with our diet. So we can eat things that are lower in sodium and watch our cholesterol really well and try to watch some of our saturated fats. We want to just have good fats and not those bad fats. Reduce the amount of calories that you take in. I think as a country here in the United States, we overeat all the time, right? And just think of all of the fast food places. They all have to supersize everything and make everything so much bigger than it used to be. So that's part of our problem. Also limit alcohol consumption, do regular exercise, do stress management, try to avoid tobacco products, and then control your diabetes, because remember we said everything is related. So even having like a messed up blood sugar can actually affect some of this stuff as well. There is a specific diet called a DASH diet that is good for high blood pressure. So in this diet, you are supposed to consume foods that are rich in fruits and vegetables, low-fat dairy products, and reduced content of saturated and total fats. So when you're looking at this picture here, like a huge portion of this is fruits and vegetables. You still can have some grains, but look at the proteins. The proteins aren't as big, right? And you like your fats and everything's like a little bit less. So that's kind of how you would look at this. This diet is aimed at stopping hypertension or improving it, and it actually does work really well from what I understand. And then things that we should educate patients about when they have high blood pressure. So educate them on how to take a blood pressure. So if they have their own blood pressure cuff, have them bring it into the office or something so you can demonstrate how to do it correctly. And sometimes it's a matter of making sure their pump is calibrated the right way, especially if they have a automatic pump. So you want to instruct patients about possible side effects of their medications. If they are on blood pressure medicine, they should avoid hot tubs, steam rooms, and spas. Excuse me. This can cause them to have low blood pressure episodes where they might pass out. They should wear support hose, because support hose actually helps push that blood flow back up to the heart, and it will help improve the blood pressure by doing that. So support hose are good. Get up slowly, dangle at the bedside, and stand up slowly, just in case you have that orthostatic hypotension. If you do have dizziness, don't get up and try to walk while you're dizzy. Just lie down or sit down for a while until that dizziness stops. And then sitting or standing for long periods of time can cause problems. It can cause you to have, blood clotting in a certain area, and that's not good. And then monitor the blood pressure regularly. So those are the big things out of this. All right, so I want us to do a case study. I'm trying to think how I want to do this. Let's see if I have this in my file here. Oh, you know what? We might have that on our Canvas. Well, darn it. Or maybe I can pull it up. Let me try and pull it up. Sorry, guys. This is just taking me a minute. I'm just trying to find something real quick to make this better. If we were actually in class, I could hand this out, and I just can't hand it out now, so it makes it a pain.
You're fine. I'm gonna go refill my coffee then.
Okay, yeah, this is it. All right, guys. Let me see. I can share this. All right, can you guys see that okay?
Yes.
All right, so this is a case study about hypertension, and normally I would hand it out in class and we would do it in class, but we'll just try and do it like this. All right, so in this, it says the patient's a 64-year-old African American man who's diagnosed with hypertension. He is 6 feet tall and weighs 300 pounds. He smokes 2 packs of cigarettes a day. He works as a salesman and has 2 to 3 alcoholic drinks a week. He admits that he does not get as much exercise as he used to when he was 40 years old. His mother and brother have high blood pressure, and his father died of a heart attack at age 68. So, does he have essential or secondary hypertension? So, basically, remember we said essential and primary are the same thing. So, is this primary or secondary hypertension? What do you think? And it also says, can this be determined at this point?
I don't think he can just yet. I think he has even had his blood pressure taken in a couple times.
Okay. So, which kind of hypertension do you think he has?
Mm.
The primary.
Yes. So, most likely it's primary, right? Or essential. But this is the thing, we can't determine this yet because in this scenario, it doesn't say that we've ruled out a secondary cause, right? So maybe he has a pheochromocytoma or he has something else going on, right? So we would have to run some tests to make sure that it's nothing like that first. Okay, so that's why this wouldn't necessarily be. Let me see if I can type this in here. All right, so this is what they say. So essential hypertension has no known cause, but several associated risk factors. He has several risk factors because, it said he already was diagnosed with hypertension, but it says he has family history of it, excessive calorie consumption, physical inactivity, all of those, common things that would play a part in having hypertension. However, it says secondary hypertension is caused by another disease process. At this point, it's unclear what the cause of his hypertension could be, so further testing is needed. Okay, the second thing says, what diseases would have made this patient at risk for developing secondary hypertension? What else could cause secondary hypertension? So think back to our endocrine stuff that we just did. What endocrine problems could cause hypertension?
Diabetes? Or am I thinking the wrong thing again?
No, you're right. Diabetes could play a part here. Yeah. What else?
Thyroid stuff? Like the hype?
Yeah, which one? Hyper or hypo?
I always get these mixed up, no matter how much I read about it. So,
Go with your first
wanna-
inclination.
huh?
Go with your first inclination.
Hyper?
Yes. Yeah, so hyperthyroidism could cause high blood pressure. What about Cushing's and Addison's disease? Which one of those could cause you to have high blood pressure?
Cushing's.
Cushing's, right? So that would be another possibility here. And then what about chronic renal disease? Can that cause you to have high blood pressure?
Yeah.
Yeah, right? All right, so those are some of the things that we would be trying to rule out then. If we were going to do other testing with this guy, we would test for some of those things. So let's see. Just gonna say that for now, so I don't have to type everything. Oh, look, it has a table. That's not helping. But yeah, so those things that we just talked about, those would be, what it would be. All right, and then how does this patient's age impact the diagnosis and treatment of hypertension?
It's harder to lose weight as you get older like that.
Okay, that's so true.
Yeah, and
I'm
all
right
them
there with you.
secrets.
But yeah, you're right. It is harder. So when people age, do they tend to have higher blood pressure then?
Yeah, I would say so.
Okay. So this is what I would tell you. And this, actually, maybe it'll show it. Let me see if I can just say. Here we go. All right, so for older adults, it's the most common for hypertension to have no symptoms. So like they could have it and not have symptoms. Once a day drug therapy is best for someone who's an older adult who gets diagnosed with this, because the more doses required each day, the higher the risk the patient will not follow that treatment regimen. So typically, like, if you have a pill that you're trying to put them on, if it's something that's twice a day or 3 times a day, they're not going to take that. So you try to put them on something that's like a once a day whatever, so that they'll be more apt to take it, So I want to read to you this real quick because I don't know why that's not on here. So as people age, their systolic blood pressure becomes more significant because it's a better indicator than diastolic blood pressure of risk for heart disease and stroke. So even though we're concerned about both numbers, the top and the bottom number, that top number is the one that we're going to focus on more, because as we age, that bottom number isn't going to be such an issue anymore. So research has shown that diastolic blood pressure rises until about age 55, and then it starts to go down. And systolic blood pressure continues to rise. So that's the one that we pay most attention to, I guess you should say. So there is a term called isolated systolic hypertension. And what that means is it's your top number, that systolic blood pressure reading at or above 140 with a diastolic blood pressure less than 90. So for older adults, it's the most common form of hypertension and has no symptoms. So that once a day drug therapy would be the way to go with an older adult, because that way you're going to make sure that they take it and they're not going to be skipping doses or anything. Okay, so during the initial workup for hypertension, what lab testing would you order? So remember, we just talked about, we said we couldn't really say if this was essential or secondary hypertension yet, because we need to run some tests. So what kind of tests would we run to tell us if this guy had any of those problems? What kinds of things would we want to look at? Do you remember when we talked about pheochromocytoma, we said, what was the best way to figure out if someone had that?
Was that the blood test?
It's a 24-hour urine.
Oh, the 24-hour urine.
Yeah. So with that one, it's a 24-hour urine. So you're specifically looking for catecholamines in the urine. What about like for Cushing's? What would you run for Cushing's to tell you that they had that?
Don't they do like saliva or something like that?
That's probably not what they would do for this, though.
Okay, because you're looking at cortisol levels, I think.
Yes, cortisol. So maybe we
Oh,
would
sweet.
draw some cortisol levels, right?
Sweet.
Also, you know, we talked about how like your aldosterone and stuff can be messed up. So you would look at all of that. What about, like, say we were worried this guy might have chronic kidney disease? How would we figure that out?
That's just a blood test, right?
Yeah, blood test. And what in particular are we looking at?
I think Ashley mentioned it earlier. You just do BUN and creatinine levels and stuff like that.
Okay. All right, so this is what they say in here. So to check for renal disease, we're going to do a urinalysis of BUN and creatinine. So we're drawing that in their blood to see what that looks like. We're going to rule out pheochromocytoma from doing a 24-hour urine and checking for catecholamines. To rule out Cushing's, we're going to look at serum corticoids and 17 keto steroids in the urine. And then we also might check for cardiac enlargement by doing a chest x-ray or something. So those would be some of the things we do to rule out, you know, secondary causes. All right, and then it says, an interdisciplinary team consult was completed. What assessment findings would indicate that successful outcomes have been met? So if we've implemented him on, you know, some medicine and stuff now, what do we want to see happen? Look back at your scenario here. What do we want to see change in this scenario?
you definitely, well, you want to get him to stop smoking. You want to put him on medication and try to get him to eat the right foods and maybe try to lose some weight.
Okay. So in order to say that our what we have implemented is successful, then we would want to see that his blood pressure's coming down, that he's eating better, maybe he's lost a little bit of weight, some things like that, right? So weight loss, he's no longer smoking, blood pressure is within acceptable limits, and then and that's going to depend on whether he has renal disease or diabetes. All right, and then the last one says the patient was later seen in the ED with severe headache, extremely high blood pressure, dizziness, blurred vision, and shortness of breath. He appears very frightened and anxious. His diagnosis is hypertensive crisis. Describe the appropriate interventions for this problem. So what would we do with this guy?
Would you give him some IV fluids?
So what
I
particular medication would we give him? Or something specific that I told you guys.
Right. Was it the Lasix or lisinopril?
No, not for this.
Not.
What was the question again? I was trying to get this to focus.
It says the patient was later seen in the ED with severe headache, extremely high blood pressure, dizziness, blurred vision, and shortness of breath. He appears very frightened and anxious. His diagnosis is hypertensive crisis. Describe the appropriate interventions for this problem.
Okay, Brandy said, what did you say, Brandy?
I was thinking you would give him some IV therapy, but
So he's hypertensive.
Yes. So what my stuff says is you would place him in a semi-Fowler's position because he's really short of breath, right? So we don't want him to be laying flat or anything. We're going to give him oxygen. We are going to give him some IV blood pressure meds. So in here, even though it says he's diagnosed with hypertensive crisis, we are going to assume that he's having some organ damage because he's so short of breath and he's having all these other crazy symptoms. So we're going to give him IV nitroprusside. That's what I was hoping someone would say. So that's going to bring his blood pressure down really quickly, and then we're going to take him off of that and put him on something else afterwards.
Oh yeah, you did say that at the beginning. I forgot the name of it just that fast, but you did say that it was that dangerous one that you only use for a certain amount of time to bring it down, and then because it was a poison or something called cyanide or something. That's the one. Okay.
Yeah. So he's going to be admitted to the critical care unit while he's on this, and they're going to monitor him really closely. So that's all that we're talking about here. Okay. All right, so with that hypertension stuff, there's just, you know, when you go through this next test, you know, the first part of the test will be like hypertensive stuff and vascular stuff, and then the second part of the test will be all the renal stuff. So it really isn't that bad. It should be fine. All right, so I do want to go over a little math with you real quick. So do you guys remember when we did just do it this way. Remember when we did like the heparin problems where we had those more elaborate ones where it said, hey, you're going to give heparin at 5 mics per kilogram per hour and this person weighs whatever. Do you remember that?
Yes.
So remember that was like the multiple step thing that you would do. So you always deal with the weight first and change the weight to make sure it's in kilograms. And then whatever your thing says, as far as like, hey, you have this many kilograms per whatever, you're going to, you know, after you change your weight, you're going to multiply it by that. So that's kind of what these two math problems are like on your test. So let me see if I can find. I just want to give you kind of an example. All right, so this one says this patient weighs 175 pounds. So someone do that for me real quick. 175 pounds divided by 2.2.
79.54 continuous.
Okay, so let's just round it to 80. Okay, because 79.5, you know, 5 and up, you'd round up, right? So let's round it to 80. All right, and then in the problem, it says they're ordered to receive dobutamine 18 micrograms per kilogram IV push.
$14.40.
What's 1440?
No, you said, what did you say? How many? You said 18?
Yeah, 18 micrograms per kilogram is what's
18.
ordered. Yeah.
So you're supposed to take 18 micrograms per kilogram. So 18 times, let's see, 18 so they weigh 80 kilograms. So 18 times 80 is 1440, right? 1,440.
Yeah, I think that's what I got. What about, how about let's try this one. So if someone weighs 328 pounds, 328.2 pounds actually, what's your change in your weight?
It's 149.18. So if you want to round it to just 149 kilograms.
Okay. And then they are supposed to get 7 micrograms of dopamine per kilogram IV push.
21?
And 43.
Wait.
I got the same thing Ashley got.
Yeah.
Okay. So see, those aren't that bad. It's not because they don't have that extra step that you would do like you would do with heparin problems. You just basically change your weight and then you multiply by whatever the order is to get what you're going to give. Because it's just asking you how many micrograms you're going to give of that medicine. You guys see what I'm saying?
So you're saying there's no, so what we just did is basically is going to be all the question asking you how much to give based on the person's weight. Okay.
Yep. Like the one question that we did, the first one, so in this one, like we changed the weights, and I forget what you said it was already for the first one. 175 divided by 2.2.
The first one was like
Oh, that was
1440. That one.
no for the weight. So
For the weight.
I think we said 80.
Yeah, it was
So-
80.
So anyway, with that one, in this particular problem, after you change the weight and you multiply it by your 18, there's one more step you have to do in that one because it wants your answer in milligrams and the medications in micrograms. So what would you do to it to make it in milligrams?
Times 5,000?
So you saying change the micrograms to milligrams? Is that was your question?
Yeah, what would you do to your value then so you would have it in milligrams for your answer?
Divide by 1,000.
Okay. So what do we say? 1440 was our answer, and we would divide that by 1,000.
I have a question.
Yes.
So you just said the 1440 you would divide by 1,000. Can you
probably
change it? Huh?
Yeah, you could probably change it beforehand too.
Okay, that's what I was going to ask you. Can we change the 18 before we even get to that point? Okay.
Yeah, you can. So anyway, that's all the math is. It's just something like that. I'll see after we're done with class here. I'll see if there's something that I could tell you to do for practice with those, just so you can practice a few things with that. Okay. Okay, so we need to go into our vascular stuff now. So I can pull that up. You see this okay?
Yeah.
Yep, I can see it.
All right. So with our vascular stuff, there's a couple of things I want you to write down in the beginning before we go on. So when we talk about vascular disease, there's different things that affect our vascular system. So there is things like pump failure, P-U-M-P, pump failure. So this is where you would have heart failure that results in inadequate blood flow to your tissues. A couple other things will affect our vascular system as well. So alteration in blood and lymph vessels. So this is where maybe your arteries become clogged by atherosclerosis, or maybe you have incompetent valves inside your arteries. And then the third thing is circulatory insufficiency of the extremities. So this is peripheral vascular diseases that are characterized as either arterial, venous, or lymphatic. So as we start talking about these different vascular issues, I want you to make sure that you can tell the difference between something that's peripheral artery disease and something that's peripheral venous disease, because there's a big difference in the two. And sometimes people get mixed up on that. So basically, those three things I just told you are things that can happen that will affect the vascular system in some way. All right, so the first thing we're going to talk about is peripheral artery disease. So we're talking about the arteries right now. So whenever you think of peripheral artery disease, you need to think about reduced blood flow through your peripheral blood vessels. And typically this is going to be caused by atherosclerosis. So remember we said atherosclerosis is just this buildup of like cholesterol and junk in your vessels that's causing you to have decreased blood flow. So this can be classified as either inflow or outflow types of problems with this. So when you think about all of these different vessels that you have, like these different arteries and things, inflow would be stuff like your distal aorta or your iliac arteries. And outflow would be like your femoral artery, your popliteal, or your tibial arteries. And then when you look at the stuff in the book, it gives you like a bunch of other stuff that's just like makes you want to blow your mind. Some of it's, so they give you some examples of peripheral artery disease. So they talked about Buerger's disease, subclavian steal syndrome, thoracic outlet syndrome, Raynaud's, and popliteal entrapment. So I'm just going to kind of give you a little blurb about some of those. So when we talk about Buerger's disease, and I'm going to tell you right now, this is just for your information, most of this, like if I asked anything, I probably wouldn't ask you something off the wall like one of these things. But Buerger's disease, this is a rare disease of the arteries and the veins where your blood vessels become inflamed, they swell, and they become blocked with blood clots. So this eventually will damage or destroy your skin and your tissues, and it can lead to infection and gangrene. And pretty much anyone who has Buerger's disease smokes. They either smoke or they chew tobacco. That's like the common denominator with Buerger's disease. All right, there's also something called subclavian steal syndrome. So what this is it's narrowing or occlusion of the subclavian artery. And because you have this narrowing of that artery, it's going to cause reversed blood flow in the vertebral artery of your arm. And it causes the blood to flow in a retrograde direction down the vertebral artery. So you get some weird signs and symptoms with this. So like you can have things like vertigo and ataxia, blood pressure differences between your arms, syncope. Your hands might show circulation problems, like they may look discolored and stuff. You can have bilateral vision changes, lots of weird symptoms. Then thoracic outlet syndrome. This is another one that it mentions. So this is when your blood vessels or your nerves in the space between your collarbone and your first rib are compressed. And this is going to cause pain in your shoulders and your neck, and also numbness in your fingers. This is caused from repetitive injuries from jobs that you do or sports. It could also be caused by an anatomical defect, like having an extra rib or something like that. And then I'm just going to mention Raynaud's disease real quick too. Raynaud's disease is where your smaller arteries that supply blood to your skin narrow and limit your blood circulation to the affected area.
Is that where like some people can get like blue fingers when they're cold?
Yeah, well, they almost look white, like the
Yeah.
color completely goes out of there. So what happens is your arteries, those little tiny arteries, they vasospasm. And your fingers and your toes are typically where you see this at, and you're going to feel numb and super cold in response to this. And things that can set it off would be really cold temperatures or stress. And the thing is, like, if you have a patient with this, if you try to warm them up to try and like get a pulse there or something, it can take 15 minutes for normal blood flow to return to the area. That's a long time, 15 minutes. Okay, with risk factors for peripheral artery disease. So hypertension would be one. So that's kind of why we talked about that with this stuff today, because it's related. High cholesterol, so hyperlipidemia, so you have, your cholesterol's way too high. Diabetes, so remember, everything's related. We just talked about that not too long ago. Smoking, and I can tell you from experience, I used to work on a unit that had a lot of vascular patients where we did vascular surgeries, and that's pretty much the common denominator with everyone is they all smoke. And the sad thing is you get them in for surgery and you do all this stuff to fix their issue, and then they still smoke and they ruin it after you just fixed them. Obesity is another thing here. Sedentary lifestyle, family predisposition, and then females are more at risk than males here, which is kind of surprising, but that's the case. And then older adult patients. So typically you see a ton of older adults that have this problem. All right, so with assessment findings, there's some specific things that I want you to really focus in on when you talk about peripheral artery disease. So the number one thing associated with peripheral artery disease is called intermittent claudication. So what this is it's pain and discomfort or fatigue that is caused by the inability of your arterial system to provide good blood flow to your tissues in the face of increased demands for nutrients and oxygen during exercise. So in plain English, let me say that one more time. So if you have peripheral artery disease, when you get up and do things, when you do any type of activity or exercise, it causes your body to have increased need for oxygen, right? To get to all of these, parts of your body. And your body has a hard time doing that because you have, like narrowed vessels. So you get more pain and discomfort, and like your legs just feel heavy and tired. So that's intermittent claudication. So anytime you would see a question that has to do with this, it's going to talk about exercise. Like, hey, my patient just said that they can't only walk 2 feet because the minute they walk further, they have this pain in their legs and whatever. That's intermittent claudication every time. Okay, other things that I want you to know about peripheral artery disease. Just really understand that this has to do with blood flow. So someone with this problem, they're not getting good blood flow to, all the parts of their body. So especially your extremities. So that's kind of what we're talking about here, more so the legs than anything, but you could be talking about an arm as well. So because you're not getting good blood flow, you're getting certain signs and symptoms. So if you were the nurse and you're assessing this patient as we're doing pulses, you know how when you do pulses on someone, you're supposed to do them at the same time on both extremities? So the reason for that is you should be trying to see if they're symmetrical, if they're the same on both sides. Does one feel the same way as the other one does? So whenever we do pulses, we want to use a light touch and avoid using only your index finger, because you could be feeling your own pulse. You know, you want to make sure that you're feeling their pulse and not your own. So typically someone with peripheral artery disease, it's not uncommon to find differences in their pulses. That's like very common. So you could have on one side, maybe they have a +1 pulse and the other side might be a +2. Or maybe there's no pulse on this side and there's a +2 on this side. So there's a difference in pulses. That's a big deal. Other things that you might see, numbness or burning pain in the feet when they're in bed. The thing is, with this disease process, you feel awful when you're laying in bed. Your legs hurt. So you have this numbness and burning pain in your feet and your lower legs when you have your feet up. So the thing that makes them feel better is putting their feet down in a dependent position. So that means instead of laying flat and supine, I swing my legs out the side of the bed and let them hang, because that makes them feel better. So you see in this picture I have on the slide, I don't know if you can tell really well, but the one leg looks a little bit lighter than the other. The other looks a little bit more red. So this is called rubor. So it's a reddish blue discoloration of the extremity. And usually this is going to be observed within 20 seconds to 2 minutes after that extremity is placed in a dependent position.
Would it be the whole leg, like upper leg as well, or does it just apply to the bottom part?
Probably just the bottom part.
Okay.
So when you see this rubor suggests severe peripheral artery damage. So this suggests that the vessels can't constrict and remain dilated. Other things that you're going to see with someone with peripheral artery disease. So if you were assessing them, you could hear a bruit over their femoral and aortic arteries. If you're doing cap refill, you know, especially on those toes, you could see a decreased cap refill. We already talked about the pulses, how those could be different. And then, believe it or not, wherever that peripheral artery disease is at in your legs, like say it's only up maybe to your ankle, you don't have it up higher than that, wherever it stops at, that's where you're not going to see any hair grow anymore. You're going to have loss of hair there. Your lower legs are typically dry and scaly. A lot of times people will look like they have mottled skin. They're going to have really thick toenails. Their extremity is going to feel cool to the touch. It's not going to feel nice and warm. And then if you did put their extremity up that has this peripheral artery disease in it, it's going to start to look really pale and white. All right, so to figure out if this is the issue, if this is what's going on, if we think they have peripheral artery disease, there's different testing things that they will send them for. So I'm not going to spend a ton of time on this. I'm just going to kind of touch on it a little bit. So they could send them for an arteriography. So this is basically like a heart cath in a way, except for your leg, you know? So this is going to confirm the diagnosis of occlusive arterial disease. So when surgery or other interventions are considered, they would want to do this to make sure that that's what's going on. When they get this done, they actually have dye that they shoot into their arteries so they could see better, like the blood flow there. So again, if someone's not able to get dye, they wouldn't be able to have this done. You can feel a sensation of warmth as the contrast agent is injected. And then, of course, if someone has an allergy to IVP dye, that's important to know here. So you wouldn't want to give them this if that was the case. Other things that sometimes they might send them for would be just like a stress test, an exercise tolerance test. This can be done with or without the treadmill, and they measure their pulse volumes and blood pressure before and after they exercise. And then there's something called a plethysmography. Again, blood pressure cuffs are attached to the upper extremities, a lower extremity, and the plethysmograph machine. And it's used to determine variations of blood through the artery. It identifies abnormal blood flow to the affected limb. One thing on here that I do want to point out real quick with these diagnostic procedures, one of the things they tend to do a lot of is this ankle brachial index. So for this procedure, they do a ratio of the systolic blood pressure in the ankle to the systolic blood pressure in the arm. And this allows the examiner to quantify the degree of stenosis. So with increasing degrees of arterial narrowing, there is a progressive decrease in systolic blood pressure distal to the involved sites. So if you ever have to send someone for this particular test, they are supposed to avoid the use of tobacco products or caffeinated beverages for at least 2 hours before their test, because that affects their test results. Okay. As far as caring for someone who has peripheral artery disease, you want to tell them that exercising is good. If they do some exercise, even though their legs hurt, that is good for them. It's going to help them build collateral circulation. You want to tell them to not cross their legs, because the more they do that, the more it's going to cut off their circulation of blood flow. Don't wear any restrictive clothing. So again, it's kind of a double-edged sword with this elevating the legs, because if someone has swelling, that's what's going to help with your swelling, is if you elevate your legs. But if they can't tolerate that because they're in so much pain, then they may not do it, So I have that here, but again, they feel better when their legs are in a dependent position. So other stuff I have here, you want to avoid any type of vasoconstriction. So if you go out in really cold temperatures, that's going to constrict all your vessels. So you want to avoid that if you can. Avoid stress, caffeine, and nicotine, because all of that constricts your vessels and makes it even worse. Vasoconstriction of vessels will last up to 1 hour after smoking or chewing tobacco. So I guess going back to what we said in our hypertension PowerPoint, we were saying that smoking can make your blood pressure affected. So if someone came in after they were smoking, you probably would want to wait even longer to take their blood pressure then. So, if you just took it in 15 minutes, it'd probably still be elevated. All right, so there's certain medications that I want you to be aware of. So when someone has this problem, if they have peripheral artery disease, you are going to put them on antiplatelet medications. And so what this does is it reduces the thickness of their blood by decreasing fibrinogen levels. It's going to enhance erythrocyte flexibility and increase the blood flow to the extremities. So some examples of antiplatelet meds would be aspirin. Clopidogrel is Plavix. So that's another really popular one that you see a lot of vascular people on. And then patoxyphilin is Trentol. That's the other name for that. And that's another really common one that people are on. So antiplatelet meds really do help this person feel better, being on that. All right, so the effects of these medications are not always seen immediately, and you do want to monitor for bleeding, abdominal pain, any coffee ground emesis, tarry stools, anything weird like that. Another thing that we're going to put these guys on is something for their cholesterol. So typically they're on a statin. This is going to relieve some of their symptoms, from this intermittent claudication. So what a statin does is it helps with that cholesterol buildup. It helps, get rid of some of that. So typical ones would be simvastatin or atorvastatin that people are on. All right, so depending on how bad your blockage is in your arteries, if you're just, slightly symptomatic, then they're just going to keep you on your medicines and encourage you to exercise and just kind of watch it. But as your symptoms get worse, then people tend to come in and they need procedures done or eventually surgery. So this is one of the procedures that they would do. It's a percutaneous angioplasty. So it's just like a heart cath, like I was saying before, but they can actually, open up your vessel from this. So what they do is they, feed this catheter into your leg, and they can even do like a balloon angioplasty with this, where they inflate the balloon inside there to where, you have this narrowing. And all it does is it as the balloon opens, it shoves all the stuff up against the walls of your vessel so that you have an opening that's bigger so you can get better blood flow. So it doesn't get rid of all of that. So you still have the cholesterol and stuff in there, but it just moves it out of the way and makes the opening bigger. Sometimes they'll put a stent in. A stent is something that kind of keeps the vessel open. It's not a foolproof thing. So a lot of people will get a stent and eventually that'll clog up and they'll need another one. So sometimes they'll do a laser procedure where they could go in and vaporize some of that plaque in there with a laser. So that could be something that you might see done. But anyway, all of those things are options that they could do while they're in there for this angioplasty. So when you get them back from this procedure, you want to watch for bleeding at the site. So typically they're going to have a groin site that you're going to be looking at. It's going to have some type of dressing or closure device on it. So you're going to look at that frequently and make sure they're not bleeding. You're also going to monitor their vital signs frequently when they come back and check their peripheral pulses every time you do their vital signs and their cap refill. They're typically going to be on bed rest with the affected limb straight for 2 to 6 hours afterwards. And then always they're on anticoagulant therapy. This is going to be used during the procedure, and then they're going to be on antiplatelet therapy for 1 to 3 months after. So even if they didn't come in on Plavix or something, they'll probably go home on it. So again, as we're monitoring them, we're monitoring their vitals. We're looking at that site to make sure it's not bleeding. And we're making sure that they have good circulation in that extremity. So that's why we're checking the cap refill and we're doing pulses and all of that. So think of those 5 or 6 P's that we talked about before with the neurovascular assessment. So all of those things, that's what you'd be monitoring for after this procedure. So if afterwards you started to see a change in the coloring, or if it felt cooler to the touch, or if this person started having extreme pain, worse than it was before, any of those things, that's a red flag. So you would always call the physician. All right, and I'm just talking about a couple other procedures here just to make you aware of some other things that they could do. There is, believe it or not, they have some kind of mechanical rotation device that they could put inside there to scrape the plaque from inside the artery. So again, that would be something else they could do while they were in for an angioplasty. But the other thing that you would go to after you've done all these procedures and things, if those things didn't work, then you could move on to surgery. So surgery is going to be this here on this slide. So arterial revascularization surgery. So when you see this like written on a test or written somewhere, it's going to be called different things depending on which vessels you're working on. So like if I have a blockage in my femoral artery, I might do a fempop bypass. You know, that's what the surgery would be called. There's an aortic iliac bypass. You know, there's all kinds. It just depends on where the blockage is at. So just know that those different names are all this surgery that I'm talking about right here. Okay, so when they do this surgery, this is used for people who have severe claudication and limb pain at rest. So even when they're just sitting there doing nothing, they have really bad pain. So these guys are at risk for losing a limb because they have such poor circulation. So that's why they want to do the surgery, to get blood flow restored back to that extremity so they don't lose their limb. So all they do, this is pretty much just like what you would do for a bypass surgery with the heart. So if you have decreased blood flow to a certain area, you pinpoint where that's at, and you find a different route to go around it. So they basically take, you know, their graft and like hook it to a vessel to go around that blockage so they can restore blood flow. And grafts can be harvested from the patient or made of synthetic material. Okay, so things to think about after this surgery. So your pedal pulses should be marked and monitored with a Doppler for strength compared to the other extremity. So they have such bad circulation to begin with that when they come back from surgery, this is super important for you to be doing, and doing it frequently. So typically when they come back, they have it marked on their foot exactly where they found their pulse. And they have some kind of like paint that they put on their foot so you know exactly where it's at. So you use the Doppler instead of feeling for it because you want to totally make sure that they have a pulse. And the Doppler is the best way to do that. So you're going to compare strength on both sides, just like you would normally. You're also going to look at the color, the temperature, the sensation, and the cap refill. So that's going to be compared to the other leg every time you check them. You're going to assess for warmth, redness, and the possible edema of that affected limb. So yes, after you have surgery, you always have edema. That's to be expected. So you're going to expect that when they come back. That's okay. You're going to monitor for pain. So when blood starts to flow through the affected artery, pain can be very severe. So typically these guys are in a lot of pain and they get, you know, IV pain medicine typically for this. You're going to monitor their blood pressure. A low blood pressure can cause their graft to collapse, so you don't want it to be too low. And then high blood pressure can also be a problem. That can cause bleeding from the suture line, you know, from the surgery. So you have to be very careful and keep their blood pressure under control. They should not bend their hip or their knee to decrease the risk of clot formation. And that's just for a short time while they're on bed rest still. Of course, after they can get up, they don't have to worry about that anymore. Okay, so these are some possible complications that you could have after this surgery. So things you'd be worried about would be that the graft occludes. So some of the things that you would see if that would happen would be during that first, so many hours after the surgery, you would see reduced or absent pedal pulses. So again, that's why it's super important to be looking at those frequently. And typically when they first come back to you from surgery, you're checking those like every 15 minutes. Like it's very frequent. If they had increased pain there, so of course they still have pain regardless, but if it's more so than what you think it should be, then that's a problem. If there's a change in that extremity color or anything like that, that's telling you there's an issue. So you would call and they would probably come back and take them back to do an emergency surgery. And they would do a thrombectomy to remove a clot from this graft. And I put here, they may need TPA. What is TPA, you guys?
I know TPN. TPA.
Anyone else have a thought?
So it's on the tip of my tongue.
Okay, so TPA means that you're going to give them a medicine that unclogs that blockage. So you remember talking before about thrombolytics? That's what TPA is. It's a thrombolytic. So if that's the case, they could have to get that in addition to going back to emergency surgery to get this clot out. So they're going to be at high risk for bleeding when they come back to you again. The other things we're going to be worried about is wound or graft infection. So you're typically going to be looking at their incision quite often to make sure that that doesn't get infected. So things like warmth, tenderness, redness, purulent drainage, all the normal things, that you would think infection, that would be what you would see here. Now, with vascular surgeries, it's kind of crazy because sometimes, depending on where this is at, sometimes you'll have an incision that's in your groin area, and those seem like they get infected really easily. So you'd have to be careful with those. The other thing would be compartment syndrome. So remember, this is always a medical emergency, and this is when you get this increased pressure inside your extremity in this confined space because you have all of this swelling that has nowhere to go. So it's going to cause, decreased blood flow, and it's going to cause you to have all of these crazy signs and symptoms. So then you're probably going to end up having to do a fasciotomy and open their leg up so that they can, expand and not have further issues. Okay. All right, so that was peripheral artery disease that we just talked about. Now we're going to move on to peripheral venous disorders. So now we're talking specifically about the veins. Okay, so with peripheral venous disorders, when you have a problem with your veins, it's going to be either because you have a blood clot, like you have a blockage of blood flow, because of something, or maybe you have some kind of injury or malformation or something of your vein, that's causing you to have not good blood flow. And then I do need you to understand too that inside of our vessels, we have valves. So you know how, like when we talk about the heart, we talk about heart valves and how it prevents things from coming back the wrong way. Like you want everything like blood flow to go one way. Well, same thing here. Inside of our vessels, we have the same type of thing. So sometimes our valves inside of our vessels are messed up. And so we'll get backflow of blood the wrong way. So those would be some common things that you would see with peripheral venous disorders. So when we talk about our veins then, we're going to talk about three different things. So VTE, which would be, hey, I have a blood clot in my vein, venous thromboembolism. So usually we get this because we have blood that just kind of sits there and doesn't move. So venous stasis. Or maybe you have some kind of blood clotting issue. So you're hypercoagulable. I can't say it. Hypercoagulopathy, or maybe you have some kind of injury to your vessel that's causing this. So thrombus formation can lead to a PE, which we talked about earlier on in the term, and that can be life-threatening. So this is a big deal. This is a huge problem. The second thing here is venous insufficiency. So when someone has that means that those valves that I was just telling you about don't work right. So instead of the blood like coming back up to the heart like it's supposed to from your extremities, the valves cause the blood to just kind of go the wrong way, and it stays down in your lower extremities, and it causes you to have all this swelling, and the blood pools down there and it dilates your veins, and sometimes you'll have like venous stasis ulcers on your lower legs and ankles because of that. You'll have a lot of times these people have cellulitis, which I'm sure you guys saw a ton of when you were at the hospital before. That's a huge problem with a lot of people, is that cellulitis. And so you'll see with venous insufficiency, it's a common issue that you'll see quite often. I know my father-in-law has this really bad. All right, and then the third thing is varicose veins. So varicose veins are just enlarged, twisted, superficial veins that can occur in any part of your body. So some people have them like not so bad, where you can just like barely see them under the skin, and then some people have them more significantly, where they actually stick out and are twisted and they actually hurt. All right, so when we talk about risk factors for these things, so things that would cause you to be more at risk for a venous thromboembolism. So remember, certain types of surgeries totally make you more at risk. So we talked about this, back when we talked about PE. So hip surgeries, total knee replacements, like all the orthopedic stuff, right? Open prostate surgery, heart failure, being immobile. So people who just sit around all the time or can't move because of being, sick or whatever. Pregnancy, you're more at risk for these. Oral contraceptives and also active cancer put you more at risk. So any of you girls who are on oral contraceptives, these totally put you more at risk for blood clots. So hopefully you guys all realize that and are being careful about that. All right, so for venous insufficiency, the problem with your valves. So sitting or standing in one position for a long period of time, this puts you more at risk for this. Obesity, pregnancy, and thrombophlebitis. All of these things put you more at risk for venous insufficiency. And then varicose veins, typically it's more of a female problem, so you don't really see it too often in males. Usually your age is older than 30. You could have an occupation that requires you to sit or stand for long periods of time in the same place. Pregnancy, obesity, family history, those types of things put you more at risk. Okay, so with our assessment findings, you definitely have limb pain. So you have an aching or a feeling of fullness or heaviness in your legs after you stand for a while. So you could have this with varicose veins, you could have this with venous insufficiency, maybe with, VTE, but yeah, that limb pain is a big deal. With DVT, that's more specific, right? So we know what someone looks like when they have that. So typically they're going to be swollen in that area. It's usually going to be in their calf. It can be red. It can be, warm to the touch. Sometimes you'll feel a hard knot there. So it's usually, some swelling and stuff going on there as well. With venous insufficiency, this is something kind of significant. With this, I don't know if you guys have ever taken care of someone before and you weren't sure how to describe what their skin looked like. Years ago, when I was a student, I was thinking about this. I'm like, I don't know how to describe this person's skin because it looks like they have brown something on their skin, but it almost seemed like dirt. It was so brown, but then like you can't scrub it off or anything. It's just there. It's brown. So brown discoloration along their ankles and extends up their calf relative to the level of insufficiency. So just like when we talked about with PAD, when we talked about how you had a decrease in hair growth there, same thing here with this discoloration. So brown discoloration goes with PVD. This person also has lots of edema because remember we said the valves aren't working right. So all this blood is staying down in their lower extremities and it's causing them to have this edema. And then those stasis ulcers, they're typically around their ankles. And those ulcers are horrible. So they drain and drain and drain. They're very wet, I guess you could say. And that's partly because of all that edema down there. They have so much fluid down there that doesn't belong that when they have these ulcers, it just causes all kinds of issues. And then with your varicose veins, so again, some people just have them really superficial and you can hardly tell they have them. Other people, they have muscle cramps associated with them, aches and pain after sitting. Some of them really itch, so you have that pruritus. So it just depends on how bad your varicose veins are. So when we talk about peripheral venous disease, some of the things we do for testing, one of the lab tests would be a D-dimer. And I talked about this, I think, when we talked about PE. So remember, a D-dimer is a blue tube of blood that you draw, and it's just measuring your fibrinogen degradation products. And it's present in the blood produced by fibrinolysis, and it's positive when there's a thrombus formation. It doesn't mean that you have like a DVT though. It could mean that it could be some type of superficial thrombus somewhere. So it could be anywhere in your body. You're just not quite sure if it's what you're thinking or not. So if they did the D-dimer early on and it came back positive, then maybe they would do further testing to see if it really is what they're thinking. Other things, for a DVT, if you think someone has that, you're going to send them for a venous ultrasound. So the sound waves provide a picture of the blood flow through the blood vessels. And then they also do a Doppler study along with that, where little or no sound is produced when the veins are thrombosed. So the nice thing about that is if you think someone has a DVT and you send them for this, they will call you with results like right away to tell you if it's positive or not. So you don't have to wait for getting results in the computer or anything. With varicose veins, one of the testing things they do for that is a Trendelenburg test. So this is where you put your patient flat on this like table and you elevate their legs. So when they sit up, like when you go ahead and sit them up, their veins will fill from the proximal end if varicosities are present. And normally they will fill from the distal end if they don't have those. So that's how you would tell if that's positive. All right, and then with nursing care, so obviously with DVT and thrombophlebitis, we want to encourage bed rest and elevate the extremity. With venous problems, elevating is really important, right? Because we want to help with that swelling. PAD, remember, you feel better with your legs down. So elevate with PVD for sure. Other things you could do, sometimes like a warm, moist compress might make that area feel better. So you could do that for comfort. You want to do thigh-high anti-embolism stockings. I put here about the IVC filter, and I know I talked about that back when we talked about PEs, how they don't really do that much anymore because of the lawsuits and stuff. So, you know, that used to be something they would do quite a lot of. All right, venous insufficiency. So if someone with that, you want to elevate their legs for at least 20 minutes, 4 to 5 times a day to help with that swelling. You want to avoid crossing the legs and wearing constrictive clothing because, again, you know, they're already having problems with blood flow. It's not going right. You know, it's not going the right way. So you don't want to make that worse by constricting things. Instruct the clients to wear elastic compression stockings and apply them after their legs are elevated. So if compression is ordered, you tell them to put them on when they're in bed and then get up and have them on throughout the day. And then you take them off at night before you go to bed. All right, so for medications having to do with these, of course, you know, if you have a DVT, we're going to put you on heparin. When we say unfractionated heparin, this is given IV to help prevent formation of other clots and to prevent the current one from getting any bigger. Before you get discharged, they'll convert you to oral anticoagulants. Usually you're going to monitor the PTT while they're on the heparin drip, right? Because that's the lab that we're looking at. We want it to be a certain thinness of their blood, right? So that's kind of what we're looking at. And then once they're on oral warfarin, we're going to be looking at the platelet count and the INR. So protamine sulfate is our antidote for our heparin. So I put that in here again just to remind everyone. And then also, sometimes, you know, if the DVT isn't that bad, it's not uncommon to see people just on sub-Q heparin instead of IV at first. So sometimes they'll do that. This is low molecular weight heparin. And enoxaparin would be an example of that. That's Lovenox. So this is used to prevent and treat the DVT. Again, warfarin is going to inhibit synthesis of 4 vitamin K dependent clotting factors. And it usually takes a while to get therapeutic. So usually 3 to 4 days before it gets just right. You're going to monitor that PTINR, and then vitamin K is your antidote. And I talk about bleeding precautions here. All right, and then I do mention thrombolytic therapy here just because occasionally, and this is more so with PAD than PVD. I guess I probably should have put it up there. But when you have someone who has really bad peripheral artery disease and they've done everything they can do for them as far as medications go and different therapies and stuff, and maybe they've even done procedures and surgery, but things are still bad, this is kind of like almost like a last resort thing to do to try and preserve their limb so they don't have to get an amputation. So when they do this, they can try to give this thrombolytic medication. They give it through the IV, and the idea is hopefully it'll dissolve the clots enough so that they'll, you know, restore blood flow enough that they'll be okay for a while. So on here I put it must be started 5 days after the development of a clot to be effective. So if you don't do that, it's not going to work. With medications, I put a couple of medications here that sometimes they'll use along with it. But anyway, the big thing with thrombolytic therapy, you have to watch for bleeding. So this can cause you to have like a brain bleed or anything like that. You know, it's a big deal. So you have to monitor them super close when you're giving it. And there's all this blood that you have to draw to monitor while you're doing this too. All right, other procedures for venous problems. I put on here about the vena cava filter, but you guys know that they don't do those very much anymore, so I'm not going to talk about that. Sclerotherapy would be something that they could do for varicose veins. So what they do for this is you go in and they put an irritating chemical solution into the varicose vein. They inject it with a syringe. And this produces localized inflammation, and it closes off the lumen of the vessel over time. So then they don't have this big, huge, sticking out vein anymore. So afterwards, they put a pressure dressing on, and they have to wear elastic stockings over it, and mild analgesics can be taken. Other things they could do for varicose veins, vein stripping. So if the varicose vein is really big, they could do this with that. They have to wear elastic bandages on the legs afterwards, elevate their legs, and do range of motion and all that afterwards. There are laser treatments for this, and also radiofrequency ablation type stuff that they could do too to help with varicose veins. Now, complications that you could see from peripheral venous disease would be, getting those venous stasis ulcers. So when you get those, they can be really hard to heal, and they often come back. So they can lead to big problems. Like they could, lead to an amputation eventually if you don't take care of it really well. So a lot of times you'll see people have wound vacs for these because these tend to really drain a ton. Sometimes they'll do hyperbaric treatments where they go in and they have to do hyperbaric treatments for like so many days in a row for so many weeks. And they're in this oxygen chamber where they get like more oxygen than they would normally in the atmosphere. And the idea is that helps those tissues, and it helps it heal a little bit better. For superficial ulcers, you can do an oxygen permeable polyethylene film type of a dressing on it. And then for deeper ones, you may have to do a hydrocolloid dressing to promote granulation and re-epitheliation. So with a PE, if the clot dislodges and settles in the lung, you have to treat with oxygen and anticoagulation. And of course, you may end up having to do an embolectomy if it's really bad. All right, and then I just put a couple practice questions here at the end. So with peripheral arterial insufficiency, so we're talking about PAD, leg pain during rest can be reduced by doing what?
Elevating?
That's lowering.
Lowering, that's what I sure meant to say.
Okay. A client is admitted with a venous stasis leg ulcer. A nurse assesses the ulcer and is expected to note that the ulcer does what?
D?
Yeah, it has brown pigmentation around it, definitely. All right, and then a nurse has an order to begin administering warfarin to a client. While implementing this order, the nurse ensures that which of the following medications is available on the unit as an antidote.
Vitamin K.
All right, a nurse is assessing the neurovascular status of a client who returned to the surgical nursing unit 4 hours ago after undergoing aortoiliac bypass graft. So they had one of those bypass surgeries. The affected leg is warm, and the nurse notes redness and edema. The pedal pulse is palpable and unchanged from admission. The nurse interprets that the neurovascular status is what?
A.
Yes. So even though you see warmth, redness, and edema, that's something that you're gonna see because they just had surgery. So it's not uncommon to see that. When it becomes a problem is when that redness is like fiery red, or the edema is like more so than it was before, and like it goes to the extreme. So this is fine. This is normal stuff. Okay, intravenous heparin therapy is ordered for a client. While implementing this order, a nurse ensures that which of the following medications is available on the unit.
D.
Yes, protamine sulfate. All right, so that's that stuff. So there's a ton of like really good handouts that go with this vascular stuff, which I wish we were in class. I just hand it to you all. It would make it so much easier. But just make sure you look at that stuff because I think it might help you quite a bit. You know, I did record that other PowerPoint from the renal stuff last week, so hopefully you guys all got to listen to that. And, you know, we'll have our tests next week. So I will see if I can get you guys some type of practice to do for math so you're ready for the math. And then remember, I just said, you know, half of this would be stuff that we did today and half of it would be renal stuff. Any questions about anything?
I know our care plans due at midnight.
Yes, our care plans due at midnight tonight, so I want them all on Canvas, so don't send them all to me in email. Okay. All right. If you guys don't have any questions, we'll just go ahead and get off here.
Thanks.
All right, thanks guys.
Bye.